Yes, once again, you cannot look at Mycobacteria and then you forget this other atypical bacteria that can usually cause you the same thing. So today we can look at this other atypical Mycobacteria that also cause skin conditions. So as we start off, you can see in this picture, someone has an ulcer on their hand. And then in this ulcer here, we think the cause is something called Mycobacteria, or the atypical type of Mycobacteria. And if you see this fish, even the fish can be infected by the bacteria. So when you come into contact with fish that is affected, you can also end up getting atypical Mycobacteria affecting your skin. So this would be a very, very brief and short lecture because there are so many conditions that we experience in this category. So for context, before you watch this video, you can first watch the video on Mycobacteria skin infections, then you know the details about the Mycobacteria itself before you can come and watch this video. So in the atypical or the non-tuberculous Mycobacteria, we look at them as some of the organs in the same class, but in this case, they are found in soil, water, and there are over 140 species that have been known, but only 25 have been isolated in human diseases. So still, they are also slow growing and rapid growing. And among the slow growing non-tuberculous Mycobacteria, we include conditions that affect the lungs, the skin, and then also soft tissues. And then the rapid growing, we can have bacteria like the Mycobacteria, Proteinatum, the asbestos, and then also chelonae. So these ones also cause soft tissue and skin infections, and it is also key to identify them and know that they also exist. So the clinical relevance is that these diseases are very common, especially in patients who are immunocompromised, those living with HIV, those that are on anti-tumor necrosis factor therapy. So they end up getting these infections from bacteria that could otherwise not cause infection in immune-competent individual. So they can also cause pulmonary disease, which will present like the normal tuberculosis of the lungs, but can also cause cutaneous manifestation or even disseminated infections that can end up affecting the different organs in the body, including lymph nodes, including glands and solid organs in the body. Still, management requires you to first identify the bacteria, together working with the radiologist, the microbiologist, and culture and sensitivity PCR. At the end of it all, if you're able to identify the bacteria, then you can start on therapy. So we classify them as either as slow growing, rapid growing, or the ones that you cannot actually culture on your agar. So the slow growers have examples including Mycobacteria, marinum, we have Kansasi, we have avium, we have intracellulari, we have hemophilium, we have ulcerans, and the rest. Then the rapid growers, we have things like Mycobacteria, abscessus, we have chelonae, we have fortunum group, and the rest. Then the non-culturable one, we know we have Mycobacteria leprae, the one which causes leprosy, and the lepromatosis. So these other two, we shall look at them at a separate video, where we shall cover leprosy, and yeah, we shall look at it separately. So to start with, we have Mycobacterium ulcerans, which is typically common, and it causes an ulcer, the one we call Brule ulcer. We know Brule is a place in Uganda, so it was also described in Uganda. And it is a slow-growing bacteria. It loves environments that are a little bit more tropical, and it infects the skin and subcutaneous tissue, giving you these chronic non-healing ulcers. Sometimes this ulcer starts as a tiny pimple, a tiny pustule that usually erodes. Then it will give you a tiny ulcer that will progressively increase in size despite your treatment. So these indolent ulcers are common, and they usually have the undermined edges. So it is also called the Brule ulcer in Uganda. When you go to other countries like Congo, the neighbors, they call it the Kasongo ulcer. So when you hear those words, they all refer to an ulcer caused by the Mycobacterium ulcerans. So as you can see here in this picture, this is the ulcer on the elbow of the child. and this is actually a case that was in Uganda. And uh, over 33 countries have reported disease ulcers. Primarily, it affects people in the rural tropical wetlands of Africa, America, Asia, and the Pacific. Transmission, not usually well understood, but sometimes it is person to person, and it can also be acquired from acoustic sources, like from maybe water, from the soils, because we know that this bacteria coexist with us in the different yeah, in the environment. Risk factors include exposure to natural water sources, lack of protective clothing, and inadequate wound care. And the pathogenesis, the latent period of this bacteria has been estimated to be around 4 months before the overt symptoms, and they have a special toxin, the mycolacton toxin, that is thought to cause the tissue necrosis and the immune suppression in that area, to, like locally, to allow for the bacteria to grow or flourish. So at least for the very ulcer, remember that we have the mycolacton as the virulent factor that propagates the ulcer. And in pathology, in the early stages, we'll have a little bit of necrosis of the dermis and the subcutaneous tissue. Then your immune system will wake up. Then it will trigger inflammatory response that will end up giving you a granulomatous picture. So you have extensive tissue damage, particularly the subcutaneous tissue, and then it will give you that characteristic ulceration. So as you can see here, this is the early phase where you have all this necrosis, tissue ulceration, and then later on, it will give you a picture which will look like this as you try to care for the wound. So the initial presentation, someone can have a painless nodule, papule, or even a flake with surrounding edema, and then this one will usually evolve into a larger painless ulcer with undermined edges. And commonly it is seen in children about 5 to 15 years of age. And in complication, you can end up extending and affecting the bone, so someone end up with osteomyelitis in about 10% of the cases. And then it will come with severe scarring, contracture, disfigurement, and then also potential deformities or loss of function of the limb that is affected. So in the laboratory, you have to do acid fast stain, and then you can also culture them, but at a slightly lower temperature than the body temperature, about 32 degrees Celsius. Then on histology, you can also see the bacilli or the bacteria. Then you can also do PCR, which confirms it in a little bit faster. So we can also take off a swab, a punch biopsy, an aspirate, and then you analyze those samples using these modalities. So still in the treatment, you will see us using rifampicin. By the WHO recommendation, you have to give rifampicin plus streptomycin, which is for about 8 weeks. And then surgery may be necessary if you want to, if you have larger lesions. Sometimes you can end up even doing amputation. So the second line, we can give rifampicin together with the amikacin or rifampicin with erythromycin. This is still for 8 weeks. At the same time, you can give BCG vaccination, and it offers a short-term protection, especially against osteomyelitis. So if you have this ulcer, you can vaccinate the patient right away so that you protect their bones. Then we can have Mycobacterium marinum. Marine, this is water, the marine, the ocean, and in this case, the pathogen is Mycobacterium marinum, and primarily affects fish. So human end up as accidental hosts as they play with as they come into contact with the fish. As you can see in this picture, this is how the fish will present with after getting this infection of the bacteria. So even fish get bacteria in this category. So common presentation after inoculation, someone will have a nodule on their hand, especially upper limbs, which is people use to manipulate fish or to handle fish. And oftentimes they can have a trichoid separate following lymphatics, and then deeper infections can occur in about 33% of the patients. This infection is also called the swimming pool granuloma or fish tank granuloma. So someone first described this in the 1926 by someone in Arizona, and Philadelphia. So the aquarium, so they discovered that the fish were having this characteristic appearance of their scales and loss of their scales with granulomatosis inflammation. And then that's when they were able to isolate the bacteria. So initially it was called the M. barinei and then Platyhoeacillus, but all these names have been dropped to just uh, reclassify it and call it just marinum because of the aquatic nature of the bacteria. So sources and of this infection mostly someone has recreational exposure to water, they go for boat riding, cruising, then they interact with maybe quarantine fish, the ones in aquarium, zookeepers, so they can end up being maybe pricked by the, 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 the fish, and then you end up inoculating the bacteria into the skin. So sometimes early on in the weekend, France, they documented some outbreaks because of this bacteria, but later on they were controlled. And sometimes people who were these fish in tanks at home, like people who are doing pod farming of fish, they can also end up being infected by this bacteria. So the incidence of this infection is estimated to be around zero point 0.2 cases per 100,000 people in the US, but in France it's a little bit lower at 0.04 per 100,000. So still in the clinical picture, someone will have lesions such as solitary nodule or pustules, which will now evolve after an incubation period of about 2 to 3 weeks. And someone can have either single lesions or multiple lesions that usually follow trichoid pattern moving along lymph nodes, and most commonly found on the extremities. So people who are swimmers, fish handlers, they're the ones that are more at risk and they present with this condition. And there's no standard treatment. However, you have to give clarithromycin and then ethambutol. These are drugs that are effective against Mycobacterium, and the treatment is usually prolonged about 3 to 4 months. And preventive measures include using of gloves and protective gears when you're handling these fish. So fishmongers and the rest need to take note. So as you can see in this picture, this is what we call trichoid pattern of separate, whereby the lesions follow lymphatic drainage in that particular area. So we also have the Mycobacterium avian intracellulare complex, the MAC complex. And in this case, these bacteria also, they'll give you skin infections that are very hard to treat, or very persistent ulcers that don't go away. And someone doing why is this ulcer healing, because you know that in the normal healing process, about maximum of 3 weeks, an ulcer should be out of the way. So if an ulcer persistent, you have to think about it being infected with Mycobacterium. And when you take off a biopsy, then you can be able to identify it. So typically, these infections are seen to compromised, especially those living with HIV, and that's when the mark can cause skin infections, particularly if someone has a pre-existing skin condition or an immune suppression that alters your defenses against the bacteria. In the clinical presentation, someone will have papules, nodules, or even abscesses. Sometimes, in rare cases, you can also get disseminated disease. So as you can see in this picture here, someone has these nodules that also look like scaphoderma, the one we saw in the previous video. So, but in this case, they able to isolate mark. And still the diagnosis is similar. You take off a biopsy, you do a PCR, and then you're able to identify. So in this management, we usually use azithromycin or rifampicin or even ethambutol, but still the treatment is prolonged because you know that these bacteria are slow growing, and oftentimes you may need to treat for several months or even up to years. So we also have another continuum, the one we call Mycobacterium fortinum complex. And in this case, this complex usually includes non-tuberculous bacteria, primarily including the M. fortinum itself, and then the chelonae and also abscessus. So these ones are usually rapidly growing and are found in skin, in soil, water, and also other environmental sources like trees, fomites. They are usually there. So it is an opportunistic infection which will only affect individuals with compromised immune system or any pre-existing skin lesions like atopic dermatitis, those conditions that alter the skin barrier. And it's associated with skin infections, soft tissue infection, especially following trauma or invasive procedures like surgeries. Sometimes people have this bacterium as normal flora actually on the skin. So when you have now a procedure like an operation, then you introduce them into skin where they now flourish, giving you the ulcers that are not healing. So clinical presentation someone will have either an ulcer or an abscess, a nodule, and sometimes these infections can also give you systemic symptoms. There'll be symptoms like weight loss, fevers that are not going away, and then loss of appetite and the rest. So diagnosis can only be confirmed after doing culture and isolation of the organism from either tissue fluid or biopsy. And still on histology, you will see granulomatous inflammation, the one that we also see in Mycobacterium tuberculosis. Still management, we give clarithromycin, amikacin, and then sometimes you can add on cefoxitin, depending on the culture and sensitivity results. But still, treatment should be for prolonged periods of time. So this is how they will look like. So in this case, this patient here that we see in this picture, had these ulcers and lesions discharged in past, like in this case with crusting, and then you see this colorate of scale, which usually shows sign of infection. And then when they did punch biopsy in this area that you see, they were able to culture and isolate the Mycobacterium abscessus. Then this is another picture where they were able to isolate Mycobacterium chelonae, causing these granulomatous lesions that we see on the hand of this patient. So this is just a reminder that the table shows you the different bacteria and how you can treat them. If it is Fortunum group, then you may need to look for things like ciprofloxacin, levofloxacin, then even Ciptrin can help you, linezolid, imipenem, and then amikacin, depending on the culture and sensitivity. And usually we don't do monotherapy. You have to use very many drug combinations at once. Then for asbestos, we can look for things like erythromycin or azithromycin, linezolid, amikacin, and the tetracyclines. So this is not really available, so we can look at things like linezolid, amikacin, and erythromycin. So if it is chelonae, we can look at for things for linezolid, amikacin, and then also clarithromycin. Thank you very much for attending this short one. But what you have to remember is that they are typical mycobacteria and cause ulcers on the skin. So the common one we have in our setting is the brulee ulcer. So every time you see a patient that is having those presentations of ulcers that are not going away, you may also be thinking about the brulee ulcer. So thank you very much. See you in the next session.